Good morning, everyone. Hi, it's Shannon Switkowski. Welcome to our final cardio hypertension echo. And I'd like to just go around the room very quickly and introduce ourselves one more time. Go ahead, Rick.
I'm Rick Carnacci. I'm the web content producer for Cardi-OH.
Hi, Jesse Lewis, project manager here at CASE.
And I'm Goutham Rao. I'm the director of the echo portion of Cardi-OH. All right, so thanks for joining us this morning. I'm anticipating this will be a relatively brief session, but it's an important session. So in the echo programs I've led in the past, the final session is reserved to tie up loose ends and mostly to address questions that we may have forgotten or that were de-emphasized throughout the curriculum. So you did receive a survey last week to describe some of those gaps that we may have left. And I was a little surprised that there weren't a whole lot of gaps. In fact, the most common comment was that we did a pretty good job of covering everything, but there's a couple areas I'd like to touch upon. And so that's where we're at right now. And if there are other questions that you think we ought to discuss, we can discuss them. I know I've said this many times, I am a primary care physician. I do see adults, but certainly I'm not an expert in adult hypertension, so I can learn just as much from you as you can from just as much for you as you can from any of the experts here. Dr. Wright, unfortunately, is unavailable, but we can start with the areas that were outlined in your feedback, and they are threefold. One is something fairly simple that I can address that I had a chance to look into prior to coming here. And there were about 3 or 4 comments about tapering antihypertensives, especially clonidine. And there are not firm guidelines with respect to tapering, at least in the latest guidelines here in the United States. But the Australians do, and interestingly, have a very nice way of tapering antihypertensives. So you might consider tapering antihypertensives when somebody's blood pressure is under good control for a prolonged period of time, and they're on multiple medications, and you feel that one or more of those is unnecessary. In no situation is abrupt tapering recommended. Depending on the agent, it can be associated with side effects, including headache, tremor, nervousness, and of course, with clonidine, rebound hypertension. But their guideline is you taper the dose by 25% every 3 to 4 months until you have you've eliminated this particular antihypertensive. And I think that slow rate of taper is intended not to prevent side effects, but because you want to keep monitoring their blood pressure to make sure that it's under good control. The other question was about clonidine. There were 2 or 3 comments about clonidine. The best information I found was in the package insert. Abrupt cessation of clonidine, I know that most of you know that, is associated with significant side effects, including rebound hypertension. And what is recommended, according to the FDA, is that you do not lower the dose more than 0.1 milligrams every 3 to 4 days, every 72 to 96 hours. So if they're on 0.2 per day, you'd go down to a half dose in 3 to 4 days, and then another half dose. And that's the only information that I've been able to find. I'm not a big user of clonidine for hypertension, so my experience with that is somewhat limited. Are there any other comments or suggestions about tapering, if we can open it up to the crowd? I think somebody's speaking, I can't. No? Okay, we've done our, oh, here's a question. Okay, Dr. Lawhorn, that's a very long taper for older patients. We're often trying to get them off because of cognitive side effects. That's an excellent point. I think that's another consideration. I think that guideline is probably only intended for close monitoring. However, if you were to taper faster, let's say over a couple of weeks, and their blood pressure is still under good control, it's probably reasonable to go a little bit faster than that, depending on the class of antihypertensives. Okay, but that's a good point. Okay, I don't think there's any other comments. Thank you, Larry, for that. I wanted to touch upon the second area, and I wanted to give Adam some time to address this. So there was a second category of questions. I want to talk about motivation and how steering people towards lifestyle changes. We'll spend the last part of our discussion about that. The other category question was, the comment was, I wish there was more about how to deal with the social determinants of health and more about how social determinants of health impact hypertension. The mechanisms may be through poor compliance, economic hardship, education, and other mechanisms altogether, and how to overcome those. And I don't expect Adam to give us the solution to all of those problems, but Adam, if you'd like to make some comments, that'd be appreciated.
Yeah, sure. So, I mean, I think like Goutham said, I probably don't have answers to all those questions today, but I do think the feedback in general is super valuable for our future ECHO series. I know that our sort of expert opening sessions were pretty clinical this time around. And so it might be an opportunity for us to shift to covering directly some of the social determinants. The challenge here is that saying social determinants is also sort of like saying like any health problem, right? Or any disease, because we have such a broad range of factors, and the solutions, just like a solution for a clinical health problem, tend to be highly varied depending on what issue someone is dealing with. Some things tend to be more proximal to a person's experiences in the clinic. So one that I often highlight for that is something like transportation. So just being able to get to the clinic is very proximate to getting to an appointment. And then some things tend to be, more sort of root cause kind of social determinants. And this could be like someone experiencing family violence. So which really is pretty far from the clinic and has a very different set of solutions than something like transportation. One of the things that we're doing in cardio, and so this is a great time for me to plug on the Cardi-OH website. We just posted on the Cardi-OH website a social determinants executive summary that was prepared by the Team Best Practices Working Group. So I would say that's a good starting point. It's by no means comprehensive, but it is a good starting point. And then the other thing that we posted was a glossary of what we considered kind of primary social determinants. And it's sort of an overview of a wide range of concepts and how they might influence hypertension. The other challenge for a group like this is just that you all are from all over the state of Ohio in places where the social circumstances vary wildly. So some of you are in more rural clinics where no patients have access to mass transit and transportation resources are scarce, and others are in urban areas that might have more dense transportation networks, for example. That's another point that I like to make, which is that social determinants are really hyper-local. So it's not just like your city or your county, it's even the very neighborhood that the patient lives in. So, and across 3 neighborhoods that your patients are in, they may have wildly different sets of social circumstances that you need to address. I love this comment from Kate, and the having restructured care teams like you would find in a patient-centered medical home are really almost essential. Having that clinical psychology and clinical social work support, because doctors weren't really trained to address all of these social issues, and it's often seems unreasonable to have you in the context of a brief less than 30-minute visit addressing all of the social problems that a person might have. So really relying on a team. I think I wouldn't mind if, so Dr. Bolin is aware of and has, I think you're presenting a poster on a particular social determinants model at the Society for General Internal Medicine coming up here this week on some preliminary data from one of these collaborative approaches. It might be nice if you could comment on that, because I think folks are generally not aware of that type of approach, Sherry.
Yeah, thanks, Adam. I've mentioned, I think this when I did the team-based care. You're talking about the one where we were referring patients electronically to 211 and having
Exactly, yeah.
computer call. And I was actually just writing something in response. I mean, I think that that's absolutely right, that working in collaboration with communities is how we're going to help address these. I'm still struck by, even in health systems that have a lot of resources to support social determinants, how we still have a lot of challenges in actually addressing them. And so, for instance, I just saw someone who we used their 3 med certification payments for their utilities, and they have asthma, and they're using their nebulizer, and now they, it was just shut off yesterday. And so I'm stuck in this place where I've called the utility company. They won't do another certification until June 8th, and she has this month and a half, and I don't think we really have anything to address that, right? I mean, there's not this sort of gap. I mean, so she's already talked to 211, she's already talked to our social worker. Do I start paying those bills? Certainly we've done some of that, right? When somebody needs an antibiotic, I might pay for it, but I think getting into utility payments is probably beyond my ability. So I think that collaborative approaches are definitely critical, but I'm also just struck by how much more we really need to do for our patients, and how we can really need to come together to come up with better solutions than what we have right now.
Thanks, Sherry. Oh, go ahead, Goutham.
Adam had already commented on Kate's comment, but Larry also mentioned that the reliance on community health workers, which I think is critically important. I think even having someone there who can educate a patient about their medications, what they're for, and what might happen if they don't take them, and the importance of hypertension, even things that we think we probably do in the clinical setting, but can be reinforced over and over time, is a relatively cost-effective way, I think, of addressing the issue. So,
yeah, I'm really glad, Larry, that you mentioned the community health worker model. I mean, I think folks, I'm not sure everybody's aware that, Ohio has really emerged as a national leader in community health workers, in part due to some fantastic work sponsored by the Ohio Department of Medicaid in really studying how we use community health workers. But then the other key thing is that Ohio is among a smaller number of states that has a certification process for community health workers through the Ohio Board of Nursing, so that and the programs are growing relatively rapidly. I know that the 2 programs in Northeast Ohio, all of their graduates are committed before they graduate from their community health worker program. I had been trying to find some just for some research projects, and the program director said, yeah, they're all committed. They all have jobs already. So if your clinic has not explored that, the evidence is beginning to show some very positive, effective results, especially across social determinants circumstances. My own work has been on patients' digital literacy and connection to internet resources and use of patient portal tools like MyChart, because if folks don't have devices or internet, they're not going to be able to do that. This is a good question by Christy about how folks are paying for community health workers. Some of the managed care plans, actually the biggest employer of community health workers in Ohio, I think right now, is the health plans. Right, good. Hub Pathways, CPC Ohio, there are a number of ways. Folks at the federally qualified health centers it may be a little bit more challenging just because of your financing model is a little bit different. I think that's probably the place where it's still pretty challenging. And unfortunately, the other big way that they're paid for right now tends to be through grant-supported projects and programs. Most of the folks at Metro Health who are in this role are on some time-limited program that's either foundation or federal grant-supported. And that's certainly not a very sustainable pathway, but I think now that we have this sort of training pathway and programs, the policy is starting to come around to recognize the value of those folks in clinics. Oh, Larry, that's great. So the person actually increases volumes for you. Yeah, I mean, I think this is true because if for better or worse, a person that you've drawn and hired from the community who maybe looks like, talks like, has some credibility that you don't have as an MD in that community, you might gain trust with your patients and really expand your panel. I think that's a really good point. I think we definitely see that. The other thing is that the range of stuff that they do probably extends pretty far beyond just hypertension. The small hypertension project that I had running, the physician team had this community health worker who was grant supported, actually doing follow-up phone calls for colon cancer screenings and mammograms, and I mean, sort of like improved quality measures on a wide range of things. So I'm really glad you brought that up, Larry. I think moving forward, it's one of the most exciting and fruitful pathways.
Thank you, Adam. So, I just wanted to highlight something that Adam had just said, and it's in my experience with ECHO, the most challenging cases we discuss are not what dose of chlorthalidone should I start with. It's really more how do I address some of the broader issues that relate to social determinants of health. And the ECHO program I've run for a long time deals with obesity, and the actual guidelines for screening for lipids, for hypertension, for metabolic syndrome, for treatment with pharmacotherapy, that's all very straightforward. You can certainly look that up elsewhere. The bigger challenge is actually communication around the issue. And I think that's probably true here as well. So social determinants of health are critically important. The other issue I think that we face that came up in terms of feedback over the last week is how do I steer my patients towards lifestyle changes that can have a positive impact on their blood pressure and of course their weight and other cardiovascular risk factors. So I'm going to start with kind of a scenario and tell you what I've learned after seeing more than 13,000 patients and having tried this for a long time, and an approach that's now been adopted by the National Academy of Medicine's Committee on Cardiovascular Risk and Obesity, on which I serve. So let's say you have the situation where you have an obese 65-year-old woman who has hypertension. And of course, you can treat her with medications, and let's say she does not have any barriers in terms of cost or adherence, but really you'd like her to lose some weight to bring her blood pressure under control. No one has ever told her that she's overweight. No one has ever discussed the issue with her. How would you raise that issue for the first time? I'm just going to throw that out there and see if we give people about a minute or so. I can tell you many of the wrong ways to do that, but which we'll talk about in a second. But any suggestions on how to open the conversation? And the method is called opening the door. I think Ann Feshko was about to say something, and I think maybe not. Okay, sorry. Give you a moment. I know some people might be typing. So.
Anne's talking, but
yeah, she's. Anne, I think you may be muted. No.
maybe her microphone's not working.
Okay. Here's the comment. Thank you, Anne. How do you feel about your weight? Okay. Okay. I'm just going to leave that out there. Any other suggestions? Oh, I'm sorry. Kriti, assess her understanding. Maybe ask her what do you think of your weight? Okay, so those are two parallel approaches, I believe. There are right and wrong ways to do it. So I did lead an American Heart Association committee around this issue. You are overweight. What are you going to do about it? Well, okay. So first of all, you cannot make assumptions that she is concerned about her weight, that she acknowledges that her weight is playing a role in her health, or that she wants to do anything about it. So what is recommended is a couple of different approaches. One is asking for permission to begin with, and that's what Dr. Sharma recommends, and he's a very well-known expert. So you would start that conversation by let's say that the lady's name is, I don't know, there's no Melanie there, so let's say the lady's name is Melanie. Melanie, would it be okay to discuss your weight for a minute or so? And if she says yes, then you can go on and say, how do you feel about it? And that is opening the door. My preferred approach, the one we've developed over a long time, is to be a little bit more direct. And let's say you would say, Melanie, I am concerned about your weight. It's aggravating, or it's making your blood pressure worse. It's also putting you at risk for diabetes and for heart disease and for other conditions. You can name whatever you want. Is this something that concerns you as well? Is this something you and I could work on together? So having tried that with kids and adults, thousands of times with residents, with attendings, creating online courses, echo programs around that specific language, no one has ever told me, absolutely not. I'm not concerned. I don't want to work on it with you. Leave me alone. Not even one time. Now, there may be ambivalence, and we'll talk about that in a moment. When someone says, yeah, that's okay. Yeah, we can talk about it. They may be very fearful, but you have opened the door because they have given you permission to discuss the issue in a sensitive way thereafter. If you do not open the door correctly, patients will often shut down because weight is a very sensitive sort of issue. It's much more sensitive to saying, how do you feel about your salt intake? How do you feel about your adherence to medications, et cetera? So when you steer people to lifestyle changes, it has to be done in a way that's very, very sensitive. Otherwise, you won't get a lot of traction. So if you were to say you need to lose some weight, you're obviously overweight. The direct approach, I think, is is something we jump to instinctively as physicians. However, is not necessarily what's recommended. And we'll get to that in a moment. So I'm happy to send you some resources about that and videos and things like that. Assessing ambivalence is a part of motivation, which we're going to get to in a moment. Thank you, Kate. So once you have opened the door, this is another barrier that we've encountered in training. So I've opened the door. I've done it, with an incredible degree of sensitivity. And they say, yeah, well, thank you for asking me. I am concerned about my weight, and I would love to work on it with you. The only other experience I've had in these discussions is someone just telling me, you need to lose weight, you need to work on it, or I'm seeking help elsewhere. So it's a refreshing change that you're discussing this with me in a very collaborative way. You better have something else to say at that point, okay? This is another major barrier. If you open the door and have nothing to offer them but some pamphlet or, well, here's the phone number for Weight Watchers, they are going to be very, very disappointed. And I've seen that happen many times as well. Well, here's a sheet on losing weight. It goes, wait a second, I thought we were going to work on this together in a collaborative way. So as Kate said, assessing ambivalence is part of it. I often get humor as a defense, which makes me feel at ease, but can stand in the way of actually talking about change. And that's an interesting comment. So I run UH's medical obesity programs now, and it is true, you have to be more sensitive with women than you do with men. But the men will often say, "Well, I'm fat, I'm disgusting," and they'll make these sorts of comments, sort of self-deprecating comments. But what the research shows is they're every bit as sensitive, and they're hurting inside as well. And that is more of a defense mechanism. And we see this in teenage boys too and stuff like that, but you have to be extremely careful about how you go about it. So now let's talk about that. The wrong approaches that I think we've written about over the last 20 years. The worst, I think I even mentioned in this course, the worst example is a resident in pediatrics who told a teenage boy that he'd be more likely to get a date for the prom if he lost weight. And the look on his face was, you had to see it. He would not speak after that. That was just so cruel. Even language such as you would look better, you'd feel better, you'd be more popular. Do not go there. It's none of our business, first of all. We don't make assumptions about people's popularity. It's not the cosmetic benefits. Never, ever emphasize them. Always talk about diabetes, high blood pressure, heart disease. And then ask them to collaborate. Ask them if they'd like to work on it. Don't even give them a chance to breathe, because there may be some other questions around, but never, ever say anything of that sort. I know that most of you won't do that, of course. So the next category of questions I think that came up. So how do we steer people? You have to open the door correctly. The next category of comments was about motivational interviewing. And some of you are very familiar. We did have some information about this, some very, very important principles, I think. One is rolling with resistance. So our instinct when someone says, well, I really wish I could pick up my, I could take my hydrochlorothiazide or other medication every morning, but I often forget. We're rushing around in the morning and I can't get it, and I can't get my refills on time, and the mail order pharmacy phone number changed, and all this stuff. And our instinct to say, look, those are all excuses. Here's what you need to take care of this now. You need to call in, make sure you get that medication, make sure you take it every morning. Is that clear? And that's very old school. And it's very, it's a place I think many of us often jump to, but it doesn't work. It's better to roll with resistance and to start by saying, for example, reflective listening, to say, let me see if I understand you correctly. You feel like your life is very chaotic and that it's hard for you to remember to take this blood pressure medicine every morning because of all the other things that are going on. And you find that circumstances are changing so often that it's very hard for you to know when and where to pick up your medication. Am I understanding you correctly? And then you will get more engagement if you do that. Everything I've learned about motivational interviewing comes from Kenneth Resnickow at the University of Michigan. So much so that I thought we would spend a little bit of time watching a video by Ken. He runs a health behavior unit and has done some remarkable work in training physicians and other healthcare professionals in motivational interviewing. He has courses that are half a day to I think 2 days in Ann Arbor. I strongly recommend, if you have any interest in this area, that you attend one of them. If you can't, you can watch this 1 hour capsule summary. We're going to watch about 12 minutes of it, just to give you a flavor of how he goes about things. There's lots of courses, lots of information about motivational interviewing out there. However, to me, the way he explains it and puts it in such a clinical context, he's not a physician, but he puts it in the context of here's what you can do in the context of a clinical encounter, is absolutely brilliant. And so rather than me trying to inadequately paraphrase a lot of his principles, I thought we could watch some of the video. Now this comes from an online obesity. I developed a lot of online obesity courses, but this is one we developed in Chicago. It's meant for internists and family physicians, those who care for adults. And my part of the teaching the course was mostly, the sort of the medical stuff, guidelines and screening and that sort of thing. So he kind of handled the behavior things. It is industry sponsored by Jenny Craig, although they did not have anything to do with the actual content. So Rick, can we maybe play the first bit? And we can stop whenever you guys feel like you've had enough.
I'd like to thank the Academy and Jenny Craig for organizing this and for making sure you all got here. Thanks for coming. I don't have any conflicts formally, but I do have disclosures that these are some of the companies that my company, which does motivational interviewing training for healthcare delivery systems and university. This is our current list of current and past clients, all of whom for the most part have paid for our services. What you're going to get today is a really pithy 1 hour version of what they usually pay for over 2 days. So you're going to get a very compressed version of something that is typically 14, 15, 16 hours. I'm going to try and build in a little bit more skills than we would in a 1 hour workshop. Often our 1 hour workshops are more teasers and a little bit more background data, but today I'm going to try to squeeze in a little bit more skills building than we might normally do in 1 hour. We will define what MI is, show it to you a little bit. Although we're not going to go over too many studies, I want to at least touch on 1 or 2 that I think might help you. Show you what's going on in adult and pediatric obesity counseling in this country. It might surprise you. And then we'll start talking about skills. And we're going to talk about asking effective questions, using reflective listening, which is the core of MI in some ways. And how do you build what we call change talk, which is probably the most active ingredient of motivational interviewing. And then chance for discussion. However, throughout, feel free to ask questions at any time. So let's start with a very basic description of the behavior change counseling process. It is fundamentally 2 components, the why phase and the how phase. The vast majority of what people do clinically is the how. Very few clinicians focus on why. And in fact, when you look at medical school, and not just medical school, the training of virtually every health professional, there's very little training on how to build a strong why. Well, in the last couple of years, we've really changed our view of what the why is and what the how is. The why currently, and it's based upon a lot of really powerful data, is building sufficient energy for change, and particularly for obesity and other chronic disease behaviors, persistence or vigilance. It is those 2 elements that motivational interviewing contributes. So motivational interviewing is the best strategy. It is the most evidence-based strategy for building a strong why, energizing behavior change, and giving the person vigilance. Vigilance, as you know, for weight loss, just like it is for addiction, is critical. You could be great 23 hours and 59 minutes, and in 1 minute they can consume that 400 calories that is the balance of the day. And the same with addiction. You could be abstinent from your drug of choice for 23 hours, and in 10 seconds, 1 snort, sniff, or puff, and that day, and perhaps your entire month or year, can be undone. How do we build that is really the focus of today. If we had more time, we'd also review the structure and strategy. Fundamentally, structure and strategy is using techniques such as self-monitoring, record keeping, weighing, changing your environment, getting rid of foods that are more tempting to you, making sure you have fresh fruits and vegetables available, and things like that. Joining health clubs if that sort of regret might motivate you because you spent that $200. Those are the sort of strategies we won't have a lot of time to talk about today. They are essential, but they're sort of necessary but insufficient. Why is the why important? Well, it turns out where you start from really predicts where you land. Quality of motivation is as important or more important than quantity. If you are strongly motivated for the wrong reasons, you have poor outcomes. This has been shown for weight loss. It's been shown for smoking cessation. It's been shown for a huge array of health behaviors. If you start out to please others, to simply achieve any sort of extrinsic vanity, even money, you tend to have worse outcomes. However, if you start from the position from, this is meaningful to me, it means a lot to me, it aligns with my values and goals, those folks do really well. MI is a technique that allows you to launch people for a behavior change attempt with high quality motivation. These are the second pieces. This is what we do during how. And again, because of time only, I won't be going into them too much detail, but it's the combination of doing good motivational interviewing to build a very powerful base for the why, combined with state-of-the-art behavior change or CBT, cognitive behavior change strategies, to build a very strong how. And when you marry those 2 things, the outcomes are better. Let me show you what MI is not. Many clinicians feel this is their job, is to come up with creative ways to restate risk. In motivational interviewing, we code this at the highest level of sin. This is pretty dirty motivation. Let's talk about this one for a second. It actually touches on a very serious issue. It turns out in public health and in primary care medicine, we share something. We are anhedonic police. We go around the world recommending things that are less pleasurable than they're currently doing. Compressed into 3 very simple rules: no more sex, drugs, or rocky road. If it feels good, stop it, or at least moderate it. Every behavior we ask them to do is against their limbic natural inclinations. There's virtually no exception to that, other than getting massage and sleeping a little bit more. Virtually nothing we recommend is intrinsically reinforcing. We are in the world that marketing calls negative demand. McDonald's is in the world of positive demand. What is resistance? Resistance is a very interesting thing. We define resistance and reactance differently. So resistance is what the patient brings into the session. Reactance is what you create when you do lousy counseling. Reactance is what we create when we express controlled motivation to our patients. It's in part because we misinterpret resistance. What resistance almost always is one of three things: dread, depletion, or fear. I dread doing this because I don't like to give up my favorite foods. I dread doing this because I hate going to the gym. I dread doing this because last time it was miserable. Depletion, I am just too darn tired. I do not have the energy to do this. And that's why we said earlier that motivational interviewing is a strategy to energize behavior change, because most patients come to you in a state of depletion. And finally, there's fear. How am I going to live life without this? I don't know what I can do to make this succeed. I've failed so many times. If this is what's propping up the tip of the iceberg of resistance, counter-arguing with patients really misses the point. So instead, what motivational interviewing teaches you in the first phase, and we'll talk about 3 phases of MI, is to roll with that resistance, is to acknowledge it, to say, you're right, this really might be miserable for you. You're really scared about this. This is not something you're looking forward to, at least the short-term process, maybe the outcome you are. By rolling with this, we end up often melting that ice. When we counter-argue with it, it actually gets more solid and colder, and you solidify their resistance. MI is actually very simple. It's just these 2 things. You can all go home now. The nuance is, when and how do you do this? What do you think are some synonyms for comfort the afflicted and afflict the comfortable? Who wants to try? What might be a synonym, either one word or a little phrase for comfort the afflicted? What is that?
Sympathize.
Sympathize, and we just use the word empathy, but there's no reason to split hairs. What do you think, and this is more difficult, afflict the comfortable is?
Sand in the oyster.
Yes, exactly. Now, because you're so brilliant, and that's actually one of the best answers I've ever heard having done this for 25 years, we call that disruption. Ours is not nearly as poetic as yours. Is we want to disrupt their current thinking about who they are and why they should do this. We want them to actually have an epiphany or an abrasive reaction that I can't do this anymore. I don't want to be that person. So this is comfort the afflicted. Roll with the resistance. Acknowledge in the first few minutes with a patient, or for sometimes it might be the entire first session, why they're scared, why they feel dread, or why they're depleted, and just to focus on that. But then if we stop there, we're just going to get caught in a loop, and the person's not going to move. So we have to disrupt. We have to build what some people call discrepancy. We have to start to make them uncomfortable with where they are. But we do it with very soft hands, and we'll talk about how do we make people feel uncomfortable without coming across as controlling, condemning, or any way that tone that we saw of that first clinician. Part of it is really affirming the good things that they're already doing. If you guys know anything about cognitive behavior therapy, or CBT, one of the core strategies we use in obesity treatment is giving yourself credit. You'll hear many people say, I'm completely sedentary. And then when you start to interview them, they're gardening, they're walking their dog, but they're just not going to the gym. So they have defined that, I'm completely sedentary. We hear that all the time also with people like alcoholics who may say, I'm completely out of control when they've cut their drinking down from 3 six-packs to 1. So the idea of giving credit for positive effort, commitments, and attempts is a core principle in the early phase of MI. I'm going to give you a chance to practice that principle right now. So take a second to read. You're now a clinician, and you're now counseling this mom. What would you say back to her? What's your natural impulse? Before you put on your MI hat, what was your natural impulse to say to her?
Wendy's is not a good choice.
Right. So the first impulse is correction. That comes from a really sort of good place in your hearts that you want people to know that you're making a mistake, and it's called the writing reflex, as we talked about a few minutes ago. Is that helpful? What's an alternative response that might be more helpful, that honors the principle of comfort the afflicted, give them credit, and affirm? What would be a statement, we call it a reflective statement, that might better capture it, other than Wendy's is no better than McDonald's?
Tell me how Wendy's is better than McDonald's.
Yes, except that's a good fact-finding, open-ended question, but it misses the point. What's ultimately going to motivate this mom? What's a reasonable guess, which is all MI is a series of reasonable guesses. What do you think might ultimately motivate her to change the family diet? What's the thing in this story?
Her kids' health.
Not eating there every day.
Yes. Say it again, sorry.
Oh, I was saying, you're not eating there every day. You are doing some other things. Tell me some of those.
Good. That's also a very good strategy. Let's hold off on that one. It's very good because there's some successes we could shine a light on. But let's start with this. This is rolling with resistance. This is acknowledging you're tired. This is affirming her concern over her kid. This is finding the meaning for change. Okay? Ultimately, if you want to really boil MI down, is you're finding meaning for their suffering. If you know Viktor Frankl, although it's a different context than how he was using his model, most people do perceive weight loss as a form of suffering, just like giving up addictions. And we have to find meaning in that suffering. Her meaning may be kids. It might be money, we don't know.
I hope we're unmuted. I wanted to share some of that. I hope that was engaging and stimulating for you. And that's just 12 minutes. 2 days, I think, was really, really inspiring. And what Ken has shown is not only that motivational interviewing can be effective in bringing about lifestyle change. It doesn't have to be obesity, obviously. He does a lot of work with smoking cessation. It can be with hypertension. It can be with anything. When the goal is a desirable behavior change, what he has shown is that even short training can have a lasting impact on how healthcare professionals approach the issue for years to come. So even that 2-day session that's attended by some primary care physician in Michigan who's just looking for an interesting CME course, what he's shown is that for months and months and even years, their attitude, their approach to counseling patients changes pretty dramatically. We are going to put this link to this video. This is a 1-hour teaser, and obviously we don't have time to share all of it with you, but it gets better, especially when we start to talk about skills. It's completely free of charge through the organization in Illinois. I think you do have to register, but and we'll make sure that you have access to it. It's listed under non-CME because you can't get credit for it because we were still developing the course at the time, and this wasn't an official part of the course. But I do recommend that you follow that video. And if you have any interest, I think he's terrific. I think there's other great people teaching this stuff, but this is the person that I've relied on a lot. So any comments or questions or suggestions with respect to motivational interviewing? Being very quiet. Okay. I'm going to wait just a second. I think somebody's typing. Okay. All right. So those were the 3 big areas. I hope we've done them some service. The issue of tapering, as I said, there's some pretty concrete information. Adam, I think, has put social determinants of health in context. And I think emphasizing that in our future curricula is going to be a priority for us, especially given the population that's the target of the ECHO series. And I think motivational interviewing, I wish we could have done more. We probably do a whole ECHO on motivational interviewing. I think there is something like that, a 12-hour session. It's very hard to do it in the echo format because practice, I think, and role playing is a big part of it. And it is actually part of this course as well. We couldn't show you that part as well. But I think those are the three elements that have come up. If there are no other elements do you believe are missing from this curriculum, I think that we've had a wonderful time, first of all. It's been a pleasure to work with the team here that is far more organized than anything I've experienced before. Plus also, I think, wonderful participants from across the state as well, who've made as much of a contribution to the course, I think, as our experts have made. So I'm very, very impressed overall. And we have our steering committee, we have the cardio committee. We'll be talking with Sherry and with Michael Constant about the best path forward. One of the things we're going to do, and I know we get a reminder, we remind you every week about the cardio conference coming up in 2 weeks' time. I think it's 2 weeks from tomorrow, right? Or 2 weeks, yeah. 2 weeks from tomorrow that we've got the course. And I think it's a wonderful opportunity if you haven't signed up yet. But we will collect feedback in many ways, informal and formal, at the course as to what the future direction of ECHO ought to be. One option is to continue this curriculum again, which has been done. I've seen that. And the hepatitis C curriculum in New Mexico has been done for many, many years because it reaches a new audience every single time. Or we could develop a brand new curriculum as well, and we'll see what the general consensus is, and we'll move forward in the fall. We generally don't have ECHO programs in the summer. I think that's a good policy across the country. Attendance is not, surprisingly, is somewhat poor, but in the fall, people are re-energized. They're ready to get back to work. Vacations are over, and it's a great time to start a new curriculum. All right, any final thoughts? Okay, if there's nothing else, we can end about 13 minutes early. Thank you so much, everyone. I hope it was a good experience for you. Take care. Bye-bye.
Thanks and congratulations, everybody.
Thank you.
Thank you.